Hey folks, Scott Weingart here, and this is an EMCrit We. Today, we're going to discuss the first of two episodes on new-onset atrial fibrillation. In this episode, basically the too long didn't listen will be, you got to start doing echoes, either before or after rate control in new-onset A-Fib, especially if the patient's younger, but probably all the time, and we'll explain some reasons why and what you might be missing if you don't, and how it may change your treatment of this patient. In the second episode, which will come in a few weeks, I'm going to discuss how to fast-track a patient with new-onset A-Fib to get cardioverted and the heck out of your department without an admission to the hospital, regardless of the onset of the atrial fibrillation, because we'll go through all of it, whether you should cardiovert versus medication, how to avoid needing the transesophageal echo in order to get these patients out without an admission. All of that will be covered. But in this episode, I'm joined by two brilliant folks from the cardiac ICU to discuss why we may be blowing off some of these new-onset AFib patients without an adequate examination and what might be missed. So let's roll right into that. So I'm super pleased to have you two here. Why don't you briefly tell us who you are and what you do, and then we'll roll right into the episode.
Sure. My name is Chris Rago. I'm a acute care NP in the CTU out in Boston.
And I'm Haval Shweish. I'm one of the pulmonary critical care physicians, work in the cardiac ICU, direct the cardiac ICU at Tufts Medical Center in Boston.
Fantastic. And now you came to me with a case that was representative of something that you folks have seen a bunch, like more than most people would expect in your practice, which is young people with atrial fibrillation treated in the standard fashion who go on to have severe cardiac dysfunction, and many of them require mechanical circulatory support. And you think there's some key points that should be brought to people's attention on these cases. Maybe as a representative case to start us off with, Chris, I think you had some case that you felt was really emblematic of this. Why don't you tell us briefly about that case?
Yeah, thanks, Scott. We do end up seeing a fair amount of patients like this. While it's relatively common for us, we obviously recognize it's rare in the general population, so wanted to highlight that. But we took care of this gentleman this past year, 55-year-old guy with a background story of hypertension and obesity. Came into urgent care initially feeling some sinus congestion and cough for a few weeks, but they found him to be an AFib with RVR. They brought him to the ED where he was looking relatively stable, blood pressure was normal. They gave him diltiazem bolus, put him on an infusion, and then admitted him to the medical ward for further workup. He had some initial labs that were slightly abnormal, just a small bump in his ALT to 70s. His creatinine was 1.15. So the next day after he was up with the medical ward, they put some metoprolol on to wean the diltiazem off. And then on hospital day 3, he had a planned TEE and was unsuccessfully cardioverted, but was found to have pretty severely reduced LV function, or the EF25. Developed some pulmonary edema that day, so got a couple of doses of Lasix, and then added amiodarone to assist with rate control for him. But things went south on hospital day 4. He had flash pulmonary edema, which was not improved with BiPAP, so was intubated, put on pressors, and then added dobutamine for inotropy, as the suspicion was he was in cardiogenic shock. That's the day we met him. He had an Impella placed at the outside hospital, and then was brought to us, still sliding and multi-organ failure. The lactate was still up. So he went on to ECMO for refractory shock on day 5. So he did unfortunately have a good outcome. It was a 8-day ECMO run in total and spent 45 days or so in the hospital. The leading differential was just an underlying tachypnea that had developed from long-standing AFib for him that was asymptomatic. Afterwards, he got cardioverted before he went to rehab, did have a few complications, was on dialysis for a good chunk of his day, had some groin wounds from the ECMO sites, and critical illness myopathy, had some time to rehab, but overall did really well.
That's fantastic. And I think that case is representative of what we want to speak about. Haval, what do you take from this case that you would have seen maybe done differently if you had your druthers?
Scott, first, thank you for inviting us. I think, as Chris said, we see this not infrequently in the cardiac ICU, but we realize that this is really small subset of what folks see in the emergency room and potentially on the medical floors. I think really important to highlight those cases because the morbidity and mortality associated with missing such cases is really high. And I think the primary really focus for us and the hope out of this is really to make sure that any patient who presents with atrial fibrillation with fast rate to really think about their cardiac function as you try to control the heart rate. And I think it's really important nowadays to really grab your ultrasound and look at the heart before you basically administer calcium channel blocker and beta blocker. I think we know from the recommendations that it's really not recommended to introduce beta blocker or calcium channel blocker in patients with decompensated heart failure. Those kind of signs of decompensated heart failure can be subtle and can be easily missed. And nowadays, having the ultrasound, quickly grabbing the ultrasound and looking at the heart function would really lead you towards either focusing more on the optimizing the cardiac function, not necessarily really blocking the heart rate, which could be just compensatory for really low stroke volume.
Yeah, I think that's fantastic. Now, I know that people in the ED are going to push back and say, I throw on the echo probe prior to the administration of rate control. I see a heart that's not performing fantastically. My natural inclination is to say that's because of how rapid their rate is. How do you address that? How are you going to discern a patient who has poor cardiac function because of filling time, they're tachycardic, and because of just the poor dynamics of the A-Fib versus a patient who has underlying cardiac dysfunction with the A-Fib being a secondary manifestation?
Really good question, Scott. I think I would push back on that. I think generally if you have really healthy heart and you go really fast, most of patients would really tolerate high rate without really getting significant trouble. So my first question is that patient clinically looking decompensated, meaning low blood pressure or any signs of metabolic derangement. And if that's the case, then it's really unlikely that the fast rate is really giving you the low flow state, unless the heart is really unhealthy, primarily with valvular disease like mitral stenosis. Those cases could really kind of decompensate with fast rate. But even if that's the pushback, if you try to control the heart in such cases, it's really important to grab the ultrasound and look at the heart after you slow down the heart with medications and see if the heart function still remains to be compromised. I think that's where you would pick on those patients where you should pause and really direct the care somewhere else rather than controlling the heart rate, trying to fix the underlying cardiac issue.
Yeah, I think that's a fantastic point. And I think at the end of this, when we have take-home message, that'll be one of them, is they certainly deserve an echo, hopefully before if they have signs of malperfusion. So any patient who has subtle indicators, like you folks had in your write-up mentioned, liver enzyme bump, creatinine bump. Obviously, if a patient is giving overt clinical signs of malperfusion, they might deserve an echo beforehand. But I think what my practice will change from the result of speaking about this is every patient deserves an echo after, if they have new onset A-Fib without explanation, to actually see what their heart function is once they slow down. Now, I guess what's pointing us to saying that this group's separate, Chris, is that this is new onset A-Fib in a young patient, which without other, primary reasons for them to be an A-Fib should make you a little suspicious. So who do you worry about, Chris? New onset A-Fib. What age is your cutoff of this is not right if there's nothing else going on? And I work in a place where a lot of people with new onset A-Fib come in with no other underlying medical problems, and we just attribute it, it's the post-bender. They probably had a big weekend of drinking with their buddies. They went out hunting, drinking beers, and that's what we attribute it to. But you're saying maybe we should consider that there's another reason, like an underlying cause of cardiac dysfunction. So who do you worry about, Chris?
Yeah, I think the tempo of the presentation has a lot to do with it and the history that they're coming in with. This year, as an example, has been pretty bad with flu A. We've seen a lot of flu A myopericarditis and kind of patients with viral prodrome leading into things that come in with A-Fib. We've had a couple 30-year-old patients that have no real risk factors or no real reasons to have A-Fib, and then the wheels start to fall off the wagon.
Hey folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Once they present. So I'd say 30s to 60s is without any underlying medical history, and Habal, correct me if you think otherwise, but should really raise the hairs on the back of your head just to be looking for those subtle signs of shock or malperfusion. It's really rare, and we see it pretty frequently, but in the community, it's definitely not as likely, and you're probably more likely to see, like you said, the alcohol related, maybe coming out off of a long weekend, or sepsis clearly is probably something way more often than these patients that slide into shock.
Habal, you pointed out that valve-related things are another reason for new-onset A-Fib, and I don't think many people are actually searching for those. So would you be recommending a routine valve check, and which valves would you actually be looking at on echo for a new-onset A-Fib patient?
Yeah, no, great question. I think just to echo Chris' point, I think younger patients, anybody really who's less than 60, I would be thinking about why they have A-Fib. I think it's really important for emergency physician, in my view. First, the question would be not how to control the heart rate right away. Just pause and ask why they have A-Fib. And if they're younger, below 60, they would be thinking about myocarditis, like viral myocarditis, or peripartum cardiomyopathy. That's another kind of subset of patients, Scott, we have seen where they have developed really bad cardiomyopathy and presented with A-Fib, which was red herring in those cases. I think nowadays immune check inhibitors, we see them leading to cardiomyopathy, just to keep that in mind. I think what you mentioned about valvular cardiomyopathy or valvular disease is really important. Primarily really mitral valve stenosis. Those patients who have mitral valve stenosis, they could really decompensate with A-Fib. And in that case, actually controlling the A-Fib does help because you need better filling time. So I think if you see somebody just falling apart and the squeeze looks okay, I would really pay attention to the valvular issues, and probably the mitral valve is a big one and the aortic valve second. Those are the ones I would pay attention to.
Fantastic. Now, the unspoken question that your case brings up is, did the patient have an underlying cardiomyopathy, whether it's from long-standing A-Fib or not, and their rate control with calcium channel beta blockers just allowed that to be revealed, or do you think it made the situation worse? Is there a contention that controlling the patient with these agents, beta blockers or calcium channel blockers, actually caused a progress of the patient's decompensation that led them to need mechanical circulatory support? So if they had gotten a more hemodynamically and heart function protective agent, say amiodarone, do you think their course would have been at all altered, both in this specific case and in general in the cases you've seen? What's your thoughts on that? Whoever wants to jump in first.
Scott, really good question. It's always easy retrospectively. We are in the ICUs and we don't want to be second guessing our colleagues anywhere, but we do believe that using calcium channel blocker and beta blocker in this case and other cases have really led to basically worsening cardiac function and going into overt cardiogenic shock. A lot of those patients, basically really the heart rate is really just compensatory for a low stroke volume. And we've seen it once you control the heart rate, still, if you do it with amiodarone or something which is less suppressive of the myocardium, better results and beta blocker and calcium channel. We're extremely cautious using those in our CCUs. Obviously, we deal with very different subset of patients, but we have seen it when it's used incidentally on the floors or in the ER, that patients really unraveled in very expedited fashion. So we do believe that it really leads to worsening of their cardiac state and leading to overt cardiogenic shock. I know, Chris, if you agree with this observation.
Yeah, it's like you said, it's easy to see retrospectively, but it does seem to be a common theme of leading to unraveling of the patient who might have been compensating with their endogenous catecholamines, or especially the younger patients that just had to have a little bit more reserve to compensate for their poor cardiac function. Once you drop the rate and then give them a negative inotrope, it really can tip them over the edge.
All right. What have we missed? What questions should we be answering that we have not yet answered?
Go ahead.
I think data, which is really, at least to me, it's surprising how common is heart failure with a new-onset A-Fib. And I just want to bring up Framingham cohort found a third of patients with a new-onset A-Fib to have a heart failure, which is really higher percentage of what I would have expected, Scott. So just something to highlight and point out here. They didn't really define how many of them were in decompensated state, which is what we're trying to basically target here. But at least you would assume that a percentage of those patients were in decompensated state, and identifying those patients with really an echo. I think if we go back and forth, it's really echo, which is your friend in this case.
Couldn't agree more. Chris, anything else you want to add before we call a close?
Yeah, I think to echo the echo, that's a very key piece of the exam while patients are presenting with new A-Fib. And also, if it's not normal, giving a call to cardiology too to help them weigh in on the case and see what their recommendations would be. I think one thing Haval always stresses is to not give up on cardiogenic shock. So these patients that tip over the edge and really are crumping is just to get them quickly to tertiary care. It's incredible what you can do with mechanical support and somebody who is really failing. And we've seen some turnarounds when they get to us in time.
Gentlemen, I can't thank you enough. I think this is absolutely a key thing to bring out. I haven't heard anyone else speaking about this, so I think it's wonderful that we now have that added to our clinical management. So thank you very much for coming on the show.
Thank you so much, Scott.
Thanks, Scott, so much.
All right, so there you go. What are the take-homes? Well, the take-home for me is, I think at this stage of the game, certainly for new-onset A-Fib, maybe for any A-Fib patient, but certainly for new-onset, either before or after rate control, depending on my level of clinical suspicion, the patient's going to get a quick bedside echo. And at least in our shop, that doesn't add any significant additional time. I mean, we're talking an additional 2 minutes. It's a billable procedure. And I think it's beneficial to really get a sense of their heart function. And is this going to happen frequently? No. I think almost all of them will be negative. But we're not talking a comprehensive exam here. We're basically just talking about one view for a second or two, maybe throwing on some valve Doppler to just make sure. But even if you didn't do that, I think even if you weren't looking for the valve stuff specifically, even if you just got a general gestalt of ejection fraction, you'd be doing a real service to these patients to figure out, oh, wow, maybe the A-Fib was, and that's the thing. The A-Fib could be secondary to an underlying cardiomyopathy, or the cardiomyopathy may have been due to the A-Fib. But in either case, I think you really want to just know, all right, I'm sending this patient out. They've now gotten either rate control or we've cardioverted them and their heart looks fantastic. They're good to go. Because you might miss the subtle signs of malperfusion. All right, let me know what you think in the comments. Scott Weingart for the EMCrit We saying bye-bye.